Good afternoon, dear students. The theme of our lecture is intestinal infection. Let's start with the definition of infection and infection diseases. Infection, the injection and proliferation of the microorganism in the host organism. Infectious process, multi-process of dynamic interaction between the infection pathogens and the host organism with the subsequent development of the various manifestations from asymptomatic duration to infectious disease. Infectious disease, an extreme form of the disease which is characterized by the presence of a living pathogen, contagious, the incubation period, and typical sequences of periods in the course of the disease. The development characteristics of the disease, clinical symptoms, and the presence of an immune response. We subdivided several phases or periods of infectious diseases. The incubation period, prodromal period, symptomatic period, and convalescence. The incubation period is the period of time between exposure and onset of symptoms of the disease. The duration of this period can range from hours and minutes, like in food poisoning, to tens of years. For each infectious disease, the incubation period has a characteristic duration, but the duration can range from a number of microorganisms penetrating into the body, their pathogenicity, and the state of a host organism. Prodromal period, the stage of the development of the disease preceding the appearance of the main pathognomonic symptoms, is characterized as a rule the subjective symptoms of illness. For example, for viral hepatitis, prodromal period is sometimes considered the end of the incubation period. The main clinical signs, but rather the patient's complaints, occurring in the prodromal period are nausea, vomiting, general malaise, fever, chills, epigastric pain, loss of appetite, muscular pain, headache, pharyngitis. Signs of jaundice, it's like yellowing of the skin, mucous membrane sclera, dark urine, discolored feces, means the end of the prodromal period, but the forms of hepatitis without jaundice may be limited only to the above-mentioned symptoms. Symptomatic period, the period of active clinical manifestations of the disease. The convalescence period begins with the date of reduction of severity of the symptoms of the disease. Depends on many factors: the severity of the disease, concomitant diseases, characteristics of the organism, as well as the quality and adequacy of the performed treatment and rehabilitation. The development and progression of the infectious process depends on properties of the pathogen, the state of the microorganism, and environmental conditions. Properties of the pathogen. You must know that the pathogen which caused development of the infectious disease is always biological agents such as virus, bacteria, fungi, protozoa, helminths. The microorganisms that can cause infectious disease are called pathogenic. Agents that cause disease in case of local and general immunodeficiency are called opportunistic pathogens. Biological agents or pathogens have the properties of pathogenicity, virulence, and invasiveness. Pathogenicity, ability of microorganism to cause the infectious process. It's a specific genetically determined trait. The degree of pathogenicity determined. Virulence is a property of the stam which manifests itself in certain conditions when the variability of microorganisms changes in susceptibility of the microorganism. Specificity is the ability to cause a particular infectious disease, such as tuberculosis, which caused by Mycobacterium of tuberculosis, cholera, which caused by the Vibrio cholera. Organospecificity is the ability to hit certain organs. For example, the flu virus or influenza virus, it's damaged the mucous membrane of the upper respiratory tract. Toxigenicity is the ability to produce exo and endotoxins. Exotoxin is excreted into the environment during the life of the organism. It's toxic substance specific, have a high antigenic activity, and formed mainly by gram-positive bacteria. Endotoxins, strongly associated with the bacterial cell and are released into the environment after the cell death. Less toxic, non-specific, the general effect of weak antigens, and formed mainly gram-negative bacteria. The virulence factors provide the adhesion of microbial cells to a sensitive host cells, its colonization, penetration, its ability of some pathogens to penetrate cells. It characterized viruses, some bacteria, while the cells die and can disrupt the integrity of epithelial cover. Invasion, ability to penetrate mucous membrane and connective tissue barriers in the underlying tissues. Aggression, the ability to suppress the non-specific and specific immune defense of the host organism. A property of the macroorganism affecting the course of infection is susceptibility. Can be species and individual. The individual is determined by the status of a specific organism and depends on the quality, intensity of invasive and aggressive properties of the pathogen and the number of pathogen at the infectious dose, the critical dose below which disease cannot develop. Condition of entrance gate. It's also one of the property of the macroorganism. It's tissue of organ through which the penetration of the microorganism is possible. So condition of entrance gate, it's connect with the general physiological reactivity, which is influenced by gender and age, the nervous system conditions, the presence or absence of somatic diseases, normal microflora, nutrition, immunological functions of the organism. The influence of environmental factors on the course of infectious process, it includes cooling, presence or absence, overheating, air pollution, solar and ionizing radiation. Also, in these factors are social conditions. So, classification of all infectious diseases, mean classification is according to the epidemiological indication based on transmission. We subdivide intestinal infection with fecal-oral pathway, infection through the mouth, alimentary with the water or maybe food. Respiratory infection. It can be aerosol pathway, infection through the respiratory tract. Blood transmissive and non-transmissive infection. When we speak about transmissive infection, we mean transmission of the pathogen through the vectors, mosquitoes, ticks, fleas. Not transmissive, it's due to injection or maybe transfusions. So it's infection through the blood which are not connect with the vectors. And the last type of infectious disease, it's infectious with percutaneous transmission. The contact pathway, infections through the skin or the mucous membrane. So, our today's lecture is intestinal infection. So, what is it? It's a group of infection diseases with a primary lesion of the intestine. Group of diseases occupying the second place in the prevalence after infections of the respiratory system. The source of the pathogen, sick person or bacilli carrier. At salmonellosis, paratyphoid B, botulism, it's often animals. Bacterial carrier can be acute, chronic, or transient. The mechanism of transmission, fecal-oral, routes of transmission, contact household with the possibility of transmission through dirty hands and household items. Water, by drinking infected water. Food, by eating infected products. Data transmission determine the prevalence of seasonal, summer and autumn and potential patients. It's very often children and socially vulnerable stratum of the population. All intestinal infection characterized by formation of epidemies, which can be contact, water, food associated. Common clinical symptoms are diarrhea, vomiting, and also intoxication. The main complication in all patients with intestinal infection is dehydration. Forms of severity of intestinal infection. We subdivided three forms: mild, moderate, and severe. Mild, characterized by syndrome of intoxication which is absent. Temperature is subfebrile or maybe normal. Stool 4-6 times a day. In the children, the first year of life, rare possible vomiting, and usually we see decreasing of the body weight. Moderate, temperature of the body 38-39 Celsius degrees, loss of appetite, lethargy, vomiting including secondary, pallor, acrocyanosis. Stool can be 8-10 times per day. Severe form, characterized by hypothermia 39 and above, repeated vomiting. Stool is 10-15 times more often. Stool loses fecal character, rectal spit, or without profuse watery stool. Develops toxemia, toxicosis with exicosis and urotoxicity, disseminated intravascular coagulation syndrome with the disorders of central nervous system, cardiovascular system, water electrolyte metabolism, hemostasis. To intestinal infections include typhoid fever, dysentery, salmonellosis, cholera, viral hepatitis, and viral diarrhea. So we start from the typhoid fever. What is it? It's an acute intestinal infectious disease which caused by Salmonella typhi abdominalis. The causative agent is the main representative of large genus of Salmonella, gram-negative microbes, the most dangerous form of Salmonella, so it's a separate form. It's entrepreneur's infection. The source is a sick man, sick person, and bacilli carrier. The incubation period is from 7 till 25 days. Infection occurs through the alimentary. The pathogen with infected water or food gets into the small intestine and multiplies in it, releasing endotoxin. Then Salmonella penetrates the mucosa without damaging the enterocytes through group and solitary follicles, lymphatic vessels, and lymph nodes, primary infectious complex, in the bloodstream. It's the onset of bacteremia typhoid fever. The diagnosis can be made by selecting the Salmonella from the blood, hemoculture. With bacteremia that persists during the first week of the disease, associated generalization of infect and the formation of humoral immunity. Starting from the second week of the disease, using serological agglutination reaction, Vidal reaction, we can detect antibodies to the causative agent. Bacteremia leads to early elimination of the causative agent, Salmonella, from the blood into the liver and then to bile ducts and gallbladder, where they find and obligate environment for their existence. Without causing clinically significant cholecystitis, Salmonella typhi multiply rapidly in the bile. We name it bacteriocholia, which fall into the lumen of the small intestine. Since then, Salmonella detected in all patients with excreta, in feces, in urine, sweet, milk of lactating women, and crop species, coproculture, and all of its diagnostic tests at the third, sometimes fourth weeks of illness. Again, with the bile getting into the small intestine, the bacteria induce a multi-stage hypersensitivity reactions in a group of and solitary follicles in connection with their sensitization when infected, the first meeting, and bacteremia, the second meeting. This reaction is terminated by necrosis and formation of ulcers. Clinical manifestation is determined by the action of endotoxin of Salmonella typhi, which have neurotropic, cardiotropic, and hematopoietic action. On the first week, we see guiding symptoms: gradual onset, complaints of headache, fatigue, insomnia, lack of appetite, constipation, or maybe diarrhea in the form of pea soup. Prolonged fever, paleness of the skin, appearance of typhoid tongue. It's when we see that the tongue thickened, densely furred gray-brown patina, edge and tipped bright red with the teeth marks. In severe cases, it's take fuliginosus kind in connection with the appearance of bleeding lateral bursting. Also, we can find sore throat duget. It's swelling of the tonsils and arch with the appearance of them small round ulcers with a grayish-white color of the bottom. Presence of cardiotropic action of salmonella lead to appearance of bradycardia, hypertension. Accompanied condition will be bronchitis. On the second week, we see appearance of fresh Roseola elevata. It's located on the anterior abdominal wall and the lateral surfaces of the body, like vest. Appears on 7, maybe 11 day. Elements of the rash slightly rise above the surface of the skin and disappear under the pressure. The number of small roseola from 3 to 12. After 3-5 days, a rash regresses. Also, characteristic symptoms of the patient on this week is plano and hepatomegaly. Sometimes we can see formation of status typhosus. It's condition which characterized by lethargy, weakness, disturbance of consciousness, delirium, headache. Also, we can see development of stupor, sopor, or maybe coma. Pathological changes, pathomorphological changes of typhoid fever is characterized by systemic and local changes. When we speak about general changes, we speak about rash formation, formation of typhoid granulomas in various organs, hypoplastic processes in organs of the reticuloendothelial system, and degenerative changes in parenchymatous organs. Local changes occur in the mucosa and lymphatic apparatus of the small intestine, multiple follicles, pair patches, and solitary follicles. So morphogenesis of typhoid fever, it includes 5 stages, each with a duration of over 1 week. So it will be medullary swelling, necrosis, ulceration with formation of unclear ulcers, after the clean ulcers, and the last stage is healing. Medullary swelling of pair patches, swelling of a group follicles, happening due to proliferation of reticular cells, some of which transformed in large mononuclear cells of macrophage origin. In the cytoplasm, which may show red blood cells, cellular debris, and salmonella typhi. Between typhoid cells can accommodate the protein fibrin and exudate. Such granulomas are sometimes completely replace the lymphoid tissue and extend beyond the corresponding lymphoid education, infiltrating the surrounding tissue. In doing so, the follicles swell and protrude above the surface of the mucous membrane, on their surface resembling the surface of the brain. On sections, they are reddish-green in color. Second stage of necrosis of pair patches, begins in the surface layers of lymphoid follicles and gradually deepens, reaching sometimes the muscular layer and even of the peritoneum. Around necrotic masses occurs the demarcation inflammation. They have inhibition by the bile, which result that the surface acquires is greenish-brownish in color. Stage of ulceration. It's characterized by sequestration and rejection of necrotic masses. Stage of clean ulcers. Formed ulcers located on the longitudinal axis of the intestinum. Their edges smooth, slightly rounded. The bottom is formed by the muscular layer. less serous membrane. Stage of healing. It's characterized by proliferation of granulation tissue. After that, with formation of fibrous tissue and also accumulation of calcium salts, this condition we name petrification. Complications of typhoid fever can be intestinal and extraintestinal. In case of intestinal, we speak about formation of the bleeding, usually it happening on a third week in the stage of ulceration. Ulcer perforation, fourth week, when we see clean ulcers, lead to the development of peritonitis usually. To extraintestinal include toxic shock, focal pneumonia with the lesions of the lower lobes, which caused by pneumococcus, staphylococcus, and less Salmonella typhi. Purulent perichondritis of the larynx with the development of the pressure ulcers and esophageal fistula. Weichsel or Sanker's necrosis. Suppurative osteomyelitis, like in this photo, and intramuscular abscesses lead complications of typhoid fever, rarely sepsis. Recovery can happen in 98–99% of the patient. Lethal typhoid fever to 1.3% of the patient, and 3–7% will be bacterial carrier. Features of present duration of typhoid fever. It's short period of the fever, rarely happening status typhosus, often recurrence, rarely non-specific complications, light or mild clinical manifestation, and often erased and abortive forms. Why it happening now? First of all, we must tell that all our patients start antibacterial treatment without any doctor admission. So when they use not effective medicines or maybe not effective for complete healing of this process, we see changes in clinical manifestations. Next disease, it's salmonellosis. Salmonellosis is polyetiological infectious disease caused by different serotypes of bacteria, Salmonella. The reservoir and the source of pathogen are sick animals. The mechanism of transmission, fecal-oral. The transfer path, it will be food through animal products. It can be eggs, milks, meat, for example. Contact household pathway. Usually it's hospital contact, and the maximum risk of infection has the children of the first year of life and persons with immune deficiency. Also, it's possible to form post-infectious immunity for our organism, but it will be effective less than 1 year. Classification. All salmonellosis subdivided into localized forms and generalized. Localized gastrointestinal and bacterial excretion or maybe bacterial carrier. Generalized, it will be a septic form, typhoid form, and flu-like. According to the duration, it can be acute, mild, and chronic. Clinical symptoms. Acute onset, intoxication. We see fever not less than 5–7 days. Also nausea, vomiting, formation of copious liquid foul-smelling, frothy dark green stool in the form of swamp slime. Epigastric pain will be present around the navel and in the ileocecal region. This region we name triangle of Salmonella. Morphologically, gastrointestinal type of salmonellosis is characterized by the catarrhal inflammation of the gastrointestinal tract, determined by hyperemia, focal necrosis, and hemorrhage. Edema also will be present of the intestinal mucosa. Hemodynamic disturbances in the forms of hemorrhages. Presence of leukocytic inflammatory infiltration of the submucosal layer. Hyperemia and degeneration of all parenchymatosed organs can be present. Generalized type has aseptic manifestations in the gastrointestinal tract, as well as multiple metastatic abscesses in parenchymatosed organs, which contain salmonella in association with the other microorganism. Usually it will be coccal flora, recorded in the proliferation of reticular endotheliocytes. Next type, it's typhoid type. It's caused by Paratyphia, or as a name it, Paratyphia A and B. It's subdivided also into a separate group since it resembles the morphology of the abdominal type, and is caused by Salmonella Paratyphia A and Salmonella Schott-Mulleri, because accompanied by the splenomegaly, enlarged mesenteric lymph nodes, swelling, hyperemia, and hemorrhages in the mucosa of the small intestine, especially in the groups of lymph nodes. So it looks like the stage of medullary swelling. What will be complications of salmonellosis? It can be development of hypovolemic shock due to dehydration. It can be, of course, vascular collapse, acute cardiac and renal failure. In rare cases or in case of septic form, we can see formation of sepsis and infectious toxic shock. Cholera. Cholera is an acute intestinal infection which caused by bacteria Vibrio cholera and L-tor. Belongs to the group of quarantine infections, highly contagious anthraconosis disease. The mechanism of infection is fecal-oral transmission path. It will be mostly through the infected water, also through the food or contact household. Cholera is endemic in parts of Asia, the Middle East, Africa, South and Central America, and the northern part of the Gulf Coast of the United States. In endemic areas, outbreaks usually occur during the warmer months. Entrance of or through the digestive tract. Cholera vibros that have overcome the gastric barriers enter the small intestine and begin to multiply there, highlighting the exotoxin, which we name choleragen. Under the action of the exotoxin, it results from the interaction of choleragen with the enzymatic systems of cells. The epithelium of the mucosa secretes large amount of isotonic fluid. In this case, the value is a blockade of the sodium pump of the cell that breaks backwards suction of fluid from the lumen of the intestine. With the abundant secretion of liquid and the violation of the reverse suction and linked with the emergence of or profuse diarrhea. In addition, its development has a value of damage of cellular and vascular membranes as a result of mucinase of Vibrio, leading to increased vascular permeability. Profuse diarrhea causes rapid loss of water and electrolyte, and dehydration lead to hypovolemic shock and metabolic acidosis, blood clots formation, development of hypoxia, progressive oliguria, and hypothermia. The progression of these processes play a leading role or critical role in causing the choleric coma. Therefore, the assessment of the degree of execosis, the other name of dehydration is execosis. We subdivided 3 degrees of execosis. It will be first, second, and third, of course. So the first characterized by a loss of from 1 to 3% of body weight, because we see vomiting up to 5 times a day, diarrhea up to 10 times, blood pressure normal, heart rate 100, and urine output normal. Second degree from 4 till 6%, it's 5-10 times vomiting, liquid stool 10-20 times, blood pressure systolic will be from 80 till 100. We see increasing of heart rate, appearance of oliguria, thirst, transient muscle cramps. And the last stage, characterized by deficiency of 7 till 9% of body weight, vomiting more than 10 times, loose stools more than 20 times, and also appearance of anuria and numerous muscle cramps. Cholera can occur subclinically in an easy and uncomplicated diarrhea, as well as rapid and potentially fatal disease. The primary clinical symptoms are abrupt, painful, watery diarrhea, stool in the form of rice water, and vomiting. Nausea is usually absent. The stool volume can exceed 1 liter in an hour. Clinical manifestations are due to stage of disease and degree of psychosis. We subdivided choleric enteritis, gastroenteritis, and algid period. Choleric enteritis, accompanied by serous or maybe serous hemorrhagic inflammation, mucosa is edematous, hyperemic, swollen. Visualized swelling of enterocytes, lymphocytes infiltration with an admixture of neutrophils. Necrosis and desquamate of epithelium, it will be main masses in the diarrhea stool. In the face of gastroenteritis, marked increased dehydration since clinical manifestation is accompanied by the accession of vomiting, the resulting shift in the face of cholera algid. The lobes of the intestinum in this case are swollen, and the lumen is a transparent, odorless liquid. Surface of intestinum and all mucosa are dry. Between lobes form exudate in the forms of threads. Microscopically, the contents of the intestine it contains epithelial cells of intestinal villi and vibrants also. Clinically, this phase probably the most significant because it's accompanied by rapid weight loss, the clotting, blood clotting, characterized by the appearance of the hypocritic face when we see pointed facial features, sunken eyes and cheeks, hands like hands of washerwoman, it's wrinkling of the skin of fingers. Post-mortem, we can determine the pose of the gladiator when we see a contorizing of muscles. Mucous membranes, subcutaneous tissues, muscles are dry, blood thick and dark. Spleen is reduced with the capsule wrinkled, atrophic follicles present, and also marked hemosiderosis of pulp. Developing the liver degeneration and focal necrosis. The gallbladder is distended due to the transparent light bile. We name it white bile. Kidney signs of acute renal failure, and in the myocardium and the brain we can find dystrophic or maybe necrobiotic changes. Complications of cholera subdivided into the specific and non-specific. Specific, it's choleric typhoid and post-choleric uremia. Typhoid characterized by hyperuricemia, which develops as a reaction to the re-entry of the Vibrio. Clinical morphological manifestation of algae disappear, and the predominant change has become like diphtheritic colitis, similar to dysentery. Splenomegaly with infarcts and hyperplasia of the pulp in the liver, multiple necrosis due to the thrombosis of the interlobular vessels. Changes in the kidney characterized by subacute extracapillary glomerulonephritis or maybe necrotizing nephrosis. Like in this photo, we see necrotic nephrosis, it's kidney, and here is signs of diphtheritic colitis. In this photo, we see numerous infarctions here and here and here. Post-choleric uremia in the cortical substance are determined infarct-like necrosis. Non-specific complications include pneumonia, numerous abscesses, phlegmon, and even in some cases sepsis. Death usually occurs from execosis in the period of algite, or more often because of the uremia formation. Next disease is dysentery, or other name is shigellosis. It's anthracnose infection which caused by bacteria of the genus Shigella. Clinically significant, there are 4 species: Shigella dysentery, Shigella flexneri, Shigella boydii, and Shigella zonai. The source of the disease, a person with an acute or abortive forms of the disease, as well as bacterial carrier. The mechanism of transmission, fecal-oral, and transmission usually happening through the food, after that water, or maybe a contact household, as well as carriers, there may be a pathway. Shigellosis is happening everywhere. However, the maximum prevalence recorded in the developing countries among population with poor hygiene and living conditions. Accessibility to shigellosis is universal, but in most cases, about 70% of cases get sick and die children under the age of 5 years. After the disease, develop a short after 1 year type-specific immunity. The incubation period averaged 2-3 days, but can range from 12 hours to 7-10 days. Classification of shigellosis provides for the allocation of the following forms and variants of the course of infection. So classification due to the pathogens, it's subdivided 4 types: Shigella dysentery, flexneri, boydii, and so on. Clinical forms: Shigella colitis, gastroenterocolitis, and gastroenteritis. Current acute, protracted, the recurrence, aggravation. Severity: mild, moderate, severe. The degree of dehydration: no dehydration, with dehydration of first, second, or maybe third degree. In the damaging mucosa of the distal colon, it can be catarrhal, hemorrhagic, corrosive, ulcerative proctosigmoiditis. Colitic form of shigellosis is prevalent in cases of disease caused by Shigella dysentery and Shigella flexneri. It's usually accompanied by intoxication of different degree and a bowel dysfunction. The onset is acute. First, it's developed a syndrome of general intoxication characterized by fever, feeling of fever, weakness, decreased appetite, headache, decrease in blood pressure. Involvement of the gastrointestinal tract is manifested by abdominal pain initially dull, but in the future they become acute. Cramping are located in the lower abdomen, usually on the left side. Appear nausea, tenesmus. The sigmoid colon is palpable as a dense, painful, or hard painful of the thickened cord. Stool frequency increases. The amount of feces each time is reduced, and a mixture of mucus and in future blood and pus. The stools lose their fecal character, take the form of bloody mucus, sometimes mucopurulent clots, we name it rectal spit. From the onset, the patient displayed weakness, apathy. Skin and visible mucous membranes become dry, pale, sometimes with a bluish tint. As a result of anorexia and fever of pain, patients refuse to eat. Heart tones are weakened, blood pressure lowered. Sometimes there is a systolic murmur over the apex, disturbance of heart rhythm. Shigella in pathogenesis, it penetrates the epithelial cells of the intestinal crypts of the colon due to the presence of invasion genes that are part of chromosomes, similar to Salmonella typhi and located in the found. Bacteria do not penetrate beyond the lamina propria. Place of life and reproduction of Shigella is a mucosal epithelium of the colon, where they are not available for white blood cells, antibodies, and antibiotics. Shigella multiply in the cytoplasm of epitheliocytes until they are absorbed by phagolysosome of epitheliocytes. With the death of Shigellas, we see production or formation of Shiga toxin, which has cytopathic activity against epithelial cells, endothelial cells of the large intestine, and the vascular glomerulus of the nephron. Cytopathic effect of Shigella in epithelial cells due to the destruction and disformation of epithelial cells, development disclamative catarrh of the colon in the initial stage of the disease also is possible. Vasopressive effect of toxin increase vascular permeability, and it leads to starting of exudation. When the white blood cells that destroy Shigella release them lipopolysaccharide endotoxin, which damages the vascular endothelium, and vascular permeability increases even more. Aggravating role of intraepithelial lymphocytes infected with the Shigella. They become target cell and as natural and T-dependent killers destroy colonocytes even stronger. Thus, the nature of morphological changes in dysentery is defined by a pronounced cytopathic effect of Shigella with the development of deep necrosis of the mucous membrane and pronounced vasopressive influence of the toxin with the development of fibrinose, usually diphtheritic inflammation. In the development of dysentery, of shigellosis and colitis with it, there are the following 4 stages. It can be catarrhal colitis, fibrinose colitis, which can subdivide it into the crupus and diphtheritic, the stage of ulcer formation or ulcerative colitis, and the stage of the scarring. Stage of catarrhal colitis lasts 2-3 days and is characterized by filling of the lumen of the intestinum of a liquid or pasty stool with the mucus and sometimes blood. The mucous membrane is swollen, plethoric, with the petechial hemorrhages covered with large flakes of whitish mucus. Microscopically, there is epithelial desquamation, edema, hyperemia of blood vessels, diapedetic hemorrhages, and diffuse leukocytic infiltration. On stage of fibrinose colitis, which can last about a week, at the height of the folds and between them there is a fibrinose film, which at first resembles a delicate scaly flakes, which are easily separated from the mucosa. Sometimes the process is confined. In other cases, the process progresses and the mucosa appears rough, dirty green crust. The intestinal wall is thickened, the lumen narrowed. Histological examination of visible deep necrosis of the mucous membrane. Necrotic masses are permitted with a fibrin and diffusely infiltrated by neutrophils with the formation of fibrinose film. Picture of diphtheritic colitis. The submucosal edema, present hemorrhage. In the nerve plexus of the colon of dystrophic and necrotic changes, which look like vacuolization, karyolysis of nerve cells, disintegration of nerve fibers with the proliferation of lemocytes. Next stage, it's ulcerative colitis, develops on 10-12th day, which begins from the rejection of the films in the form of small or larger pieces, melting fibrinose necrotic masses, and the formation of the ulcers. Ulcers with dysentery have an odd shape, their edges uneven, sometimes considerable depth. The bottom is covered with yellowish masses. Greater diameter is directed across the lumen of the intestinum. Stage of the healing of ulcers is characterized by a process of regeneration that continues for about 1–2 weeks. The fat of the bowel wall are filled with the granulation tissue at first, and then major fibrotic tissue. In the case of small ulcers, regeneration is complete. The extensive and deep ulcers scarring, deforming the wall and uniformly narrowing the lumen, or in the form of narrow transverse mounted bands, strictures. The above picture of the disease is characteristic of dysentery caused by clinical dysentery is always worse. Dysentery caused by Shigella flexneri and zoni is much easier. The process has the character of catarrhal gastroenterocolitis. In children with dysentery, solitary and group follicles are usually primarily affected, and we see hyperplasia of lymphoid tissue, central necrosis, and purulent fusion. In this case, we speak about follicular colitis. After removing pus, a small ulcer with overhanging edges and very narrow outlet, follicular ulcerative colitis, remains in the place of each follicle. Severe changes in the intestine developed when layered on a dysentery of staphylococcal or maybe other infection, manifested by suppurative and destructive changes. In these cases, extensive margin ulcers occur, which when healed form gross scars that deform the intestinal wall. In rare cases, anaerobic infection with the development of gangrenous colitis also is possible. Sometimes dysentery requires a protracted or maybe chronic duration. General changes in dysentery are non-specific. Usually mild hyperplasia of lymphoid tissue develops in the spleen and moderate dystrophic changes in the myocardium and liver. In severe forms of the duration of the disease, small focal necrosis in the liver and necrosis of the renal tubule epithelium also are possible. Complication of shigellosis also subdivided into intestinal and extraintestinal. Intestinal complications include perforation of the ulcer and subsequent peritonitis, or maybe abscess formation and phlegmon of the bowel. Intestinal hemorrhages or bleeding also can be present. To extraintestinal complications, we include bronchopneumonia, pyelitis and pyelonephritis, serous arthritis that usually occur due to the activation of autoinfection, and pyelophlebitis abscesses of the liver, which can be a result of microperforation of ulcer. With chronic diseases may develop cachexia and amyloidosis. Among the possible complications of shigellosis, it's necessary to pay attention to the following. It can be infectious toxic shock, hypovolemic shock, perforative peritonitis, intestinal bleeding, purulent meningitis, meningoencephalitis, brain abscess, ureteritis, cystitis, and etc. In the later stages, after 1–4 weeks from the onset of the disease, can occur in the different localization arthritis, iridocyclitis. Acute shigellosis in most cases ends in complete recovery. Death in adults is rare, mostly in elderly persons with burdened premorbid background and children up to 1 year. Mortality from shigellosis in developed countries does not exceed 0.1%, but in developing countries it can reach 30% or even more. The main cause of death in patients with colitic form is a toxic shock, and in patients with gastroenterocolitic form, hypovolemic shock. Amoebiasis. It's infectious protozoal disease characterized by ulcerative lesions of the colon, the tendency to the formation of abscesses in various organs, and chronic duration. Amoebiasis is widespread mainly in countries with tropical and subtropical climate. According to WHO, about 10% of the global population of people infected with the amoeba. The annual incidence of amoebiasis is 50 million cases. The mortality rate of it is 0.2%. The source of the pathogen is the person releasing with feces the cyst of amoeba. The mechanism of transmission: fecal, oral, transmission path: water, alimentary, contact, household. Factor of transmission amoebiasis can be food, water, household items. Transmission of viral sexually transmitted among homosexuals. The degree of infection of the population depends on, water supply, sanitary condition of settlements. The disease is prevalent in areas with hot and dry climate and is mostly sporadic. Cyst of amoeba fall into the stomach with water or food, goes into the intestine without significant changes. In the small intestine, the shell of the cyst is dissolved, freed from the amoeba. After division formed 8 core amoebious trophozoites, who go down to the place of parasitism and the upper parts of the colon, where they continue to multiply and form a transient form of amoebas, which live in the lumen of the large intestine, feeding on bacteria, fungi, detritus. In this case, the development of the infection can occur according to the type of asymptomatic carriage. Under the influence of several factors, immunodeficiency, dysbiosis of the colon, fasting, stress, etc., its light form of dysentery amoeba can turn into tissue forms of parasites. Under the influence of cytolysins and proteolytic enzymes of amoeba occurs when damage to the mucosa, where the pathogen multiplies intensively, forms the primary focus in microabscesses, which are opened into the cavity of the colon with formation of ulcers. Ulcers are uneven, septate. The bottom is covered with necrotic masses of dark gray color, arranged in groups of singly, often in the transverse direction. They can merge among themselves, forming extensive up to several centimeters lesions. Lining the intestines is no synchronicity in the development of ulcers. It can simultaneously detect small erosions, flowering ulcers, the healing of ulcers and scars after healing of ulcers. Often, ulcerative process develops in the cecum and ascending part of the colon, less frequently in the sigmoid and rectum. Perhaps the defeat of the entire colon. In chronic amoebiasis, in the wall of the intestine accumulates a large mass of granulation tissue to form tumor masses. We name it amoeboma. As a result of penetration of amoeba in the mesenteric vessels, is the introduction of the parasite to other organ where abscesses develop. Most often, abscesses are formed in the liver, rarely in the lung, brain, kidney, or maybe pancreas. Acquired immunity in amoebiasis is unstable, non-sterile, does not protect against relapse and reinfection. Depending on the clinical manifestations are the following forms of amoebiasis: intestinal amoebiasis, which can be acute and chronic, and extraintestinal. It's amoebic abscess of the liver, of the lung, amoebic brain abscess, genitourinary amoebiasis, cutaneous amoebiasis. Intestinal amoebiasis or amoebic dysentery is the most basic and common form of infection. The incubation period lasts from 1-2 weeks to several months. Onset can be acute or prodromal phenomena in the form of nausea, headache, decreasing appetite. The main symptom of the disease is a disorder of the stool. First, to copious with the mucus 5-6 times a day. After 4-7 days, he loses fecal character, has glassy mucus mixed with the blood formation, and we name it raspberry jello. In the acute phase of the disease may persist and cramping abdominal pain, possible option for preemptive destruction of different parts of the colon. Often there is a bipolar ecosystem option. In case of lesion of the rectum appear painful tenesmus. In amoebic disease, perhaps the defeat of the veriform appendix, which is manifested by symptoms of appendicitis. Body temperature is normal or slightly elevated. Intoxication is not expressed. Colonoscopy detects swelling, photo of hyperemia, 5-15 millimeters in diameter. On the folds of the mucous membrane, there are small raised nodules that 1-2 weeks are formed slit-like ulcers with dermatose, slit-edged, and bottom with the necrotic masses. Ulcers surrounded by a belt of hyperemia. The mucous membrane outside of the affected areas little changed. Acute symptoms of intestinal amoebiasis remain usually 4-6 weeks. Then the condition of patient improves, there comes remission. In an immunocompromised individuals on the background of treatment with corticosteroids, or maybe in pregnant women, in children under 2 years, there has been fulminant intestinal form of amoebiasis, which is characterized by extensive expression of the whole colon, bleeding, perforation, peritonitis, and toxic syndrome. In rare cases, patients find amoeboma. It's specific inflammatory granuloma, localized more often in the cecum and ascending colon. On palpation, the abdomen feels like tumor formation. Endoscopy may mistakenly be regarded as a cancer or maybe sarcoma. Disappears after specific therapy. When intestinal amoebiasis can develop, we can speak about formation of several complications, which are usually connected with the damaging of course, intestinum. And if we see presence of ulcer in patient, of course, we are afraid by formation of perforation, peritonitis, bleeding, gangrene of intestinum because of the amoebic etiology, and it can invite into appendix. We can speak about formation of specific appendicitis, which is also a complication of intestinal amoebiasis due to healing of ulcers, excessive growth of fibrous tissue, which lead to formation of structures. And of course, secondary infections also can be one of complications of intestinal amoebiasis. From extraintestinal forms of amoebiasis is most common amoebic liver abscess. It can develop in acute intestinal amoebiasis or a few months. However, indication of intestinal amoebiasis in history, they are only in 30-40% of patients, and amoeba in the feces are detected only in 20% of cases. Single abscesses are localized in the posterior right lobe of the liver and in the upper part. The onset usually is acute, with a rise in the body temperature to 39 Celsius degrees and above, presence of symptom of intoxication, fever remittent, hectic, continuous or irregular, accompanied by chills and sweating, pain in the right hypochondrium, the liver usually enlarged, painful in the area of the damage. The pain intensified by coughing, shaking, and the change of body position. However, the deep location of the abscess in some cases cannot accompanied by the pain. Sometimes we see development of the jaundice. Duration of symptoms not more than 10 days. In such cases, quickly develop complication of amoebic abscess of the liver, a breakthrough in abdominal cavity with the development of peritonitis, or in cardiac back with the development of pericarditis. The lethality of this disease without specific treatment reached 25% and higher. Amoebiasis of the lung develops in hematogenous spreading of amoeba in the lungs, or in the breakthrough of liver abscess into the pleural cavity. Characteristics of them is the fever, chills, chest pain, cough, hemoptysis, radiologically determined by the cavity and the diseased lung. Abscesses of the lung often lead to purulent pleurisy, formation of empyema, pneumothorax, hepatic pulmonary fistula. Upon the occurrence of amoebic disease in the brain in patients, noted the development of focal and general cerebral symptoms. Neurological symptoms depend on the localization of abscesses and the extent of involvement of brain center. Ante-mortem diagnosis is difficult. Thank you for your attention. Our lecture is finished.